Bismillahirrahmanirrahim. And verily your Lord will give you so much that you will be pleased. Assalamu alaikum. My name is Dr. Momina Zia. I am a PGR in Community Medicine Department. Today I'm going to present the topic of communicable diseases, mumps, under kind supervision of Professor Dr. Saira Afzal. The agenda of today's presentation will include introduction, epidemiology of mumps, clinical presentation, complications, preventive measures, and vaccination strategies. Recent updates on outbreaks and global vaccination efforts, final tips and takeaways. The learning objective will be by the end of the presentation, participants will be able to describe mumps in terms of its epidemiology and clinical presentation, complications, prevention, and treatment, and solve MCQs. Mumps in overview. Mumps is a highly contagious viral infection caused by single-stranded negative sense RNA, the mumps virus, a member of the genus Rubella virus in the Paramyxoviridae family. So the name comes from the British word to mump, that is grimace or grin. This results from the appearance of patient as a result of parotid gland swelling, although other agents can also cause parotitis. Clinically, mumps is usually defined as acute unilateral or bilateral parotid gland swelling that lasts for more than 2 days with no other apparent cause. There is one serotype of the virus and many others that affect the patient and can be found in body fluids, including cerebrospinal fluid, saliva, and blood. So the virus can also be grown in cell cultures and in eggs. Characteristic of mumps virus in overview. It belongs to the Paramyxoviridae family of genus Rubella virus. The genome consists of single-stranded negative sense RNA. It has a capsid which is helical in structure. That it is enveloped. Lipid bilayer is present in the envelope which contains the viral glycoproteins. Surface glycoproteins consists of hemagglutinin neuraminidase and fusion protein. HN protein is responsible for host cell attachment, while fusion protein is responsible for facilitating the viral entry into host cells. It replicates inside the cytoplasm of host cells. It has tropism for salivary glands, mostly parotid, testes, ovaries, pancreas, and meninges. It is sensitive to heat, UV radiation, and desiccation, and it is also inactivated by detergents and desiccants. Disinfectants. It can cause a systemic infection through viremia. And is the only known natural host and the disease is found worldwide. There is no carrier state. Global prevalence. It has sporadic cases and outbreaks, especially in under-vaccinated populations, endemic areas, Africa, Asia, and parts of Europe. Recent outbreaks. 2022 to 2023 recent outbreaks clusters are reported in part of USA, UK, and South Asia. Outbreaks, they are linked to vaccine hesitancy and waning immunity in vaccinated individuals. Now, source of infection. Patients with characteristic parotid gland swelling, they are the most identifiable source. About 20 to 30% of infected individuals, they may have a subclinical infection, but can still transmit the virus. Period of infectivity is 2 days prior to the onset of symptoms of parotid swelling, in which the patient will experience fever, headache, myalgias, etc., but no probable swelling is there, and it continues to be infective up to 5 days. So a total of 7 days will be the period of infectivity. Mode of transmission, coughing, sneezing, or talking releases droplet containing the virus, or via direct contact with saliva of the infected person, or via fomites, like toys, tissues, or surfaces. Risk factor, the close contact setting, crowded environments like schools, unvaccinated population, and immunocompromised individuals. Peak incidence is observed in late winter and spring months. This seasonal trend is, however, linked to increased indoor crowding during colder months, facilitating the respiratory transmission. With the widespread use of the MMR vaccine, the classical seasonal pattern of mumps has become less pronounced in many regions. Now, an overview. The virus, it enters through the respiratory tract and grows in the salivary glands and local lymphoid tissue. And then it spreads to the spleen and distant lymphoid tissue, resulting in viremia, the virus in the blood. And then the virus through this blood travels to other organs like testes, ovaries, pancreas, thyroid, salivary gland, and results in disease complications. This part depends upon the immunity of the susceptible individual. If the person is immune, the complications will not occur. Now, the pathogenesis, the virus, it triggers an inflammation and edema, especially in the parotid glands due to cytopathic effects, which is damaging to the host cells, or immune-mediated response can be seen. So the virus, mumps or parotitis diagnosis of childhood is acquired from the direct contact with infected saliva or aerosols from infected patients. The mode of entry is respiratory tract. Incubation period is 16 to 18 days. Virus multiplies in the upper respiratory tract and local lymph nodes, enters bloodstream and spreads to salivary glands, testes, ovaries, pancreas, kidneys, and brain, resulting in non-suppurative inflammation of the parotid gland. The virus is shed in saliva 6 days before to 1 week after the onset of clinical parotitis. Now, the clinical presentation. Number one is the prodromal phase, in which the non-specific symptoms like fever, malaise, myalgias, headaches, they can be seen, and it lasts for about 1 to 2 days before parotid swelling arise. So, what causes this prodromal phase is viremia that triggers the immune response of a host that would result in the release of cytokines, and these cytokines then mediate these reactions. Number two is parotid swelling. So the virus targets the ductal epithelial cells of the parotid glands, causing cellular damage, inflammation, and edema, leading to blockage of the parotid ducts and gland enlargement. So this enlargement then further subsides in 7 to 10 days. Along with this condition, there are two conditions associated, which is trismus. It is the inability to open the mouth, and tenderness. These are associated with it. Next is resolution. If the immunity is there, the mostly individuals, they have this resolution that occurs via number one, release of cytokines, which results in the fever malaise, and number two is neutralizing antibodies IgM in the acute phase and later IgG. So this IgG then would result in the lifelong immunity. However, if the resolution does not occur, there are certain complications that can be seen in certain individuals, like adolescents and adults. They are at a higher risk compared to the young children. Immune compromised individuals have a higher likelihood of severe disease, and unvaccinated individuals, they are more prone to severe disease and complications. Now, we'll study the complications under five subheadings, like glandular complications, nervous system complications, other organ specific complications, pregnancy related complications, and the long term sequelae of the infection. Number one is glandular complications. So the most common complication associated with this mumps is orchitis, which is the inflammation of one or both testicles in post-pubertal males. It affects about 20 to 30% of males, and symptoms include testicular pain, swelling, and tenderness. It rarely causes infertility, but may lead to testicular atrophy. Similarly, in case of females, oophoritis can be seen, but it is quite less, which is about 5% inflammation of ovaries. The symptoms include pelvic pain, fever, and tenderness, and no significant impact on fertility has been seen. Males, parotitis complication can cause abscess formation. This can also happen in females. Mastitis in females. Breast inflammation, mainly in adolescent and adult females. It presents with breast pain, redness, and swelling. Moving on to the other nervous system complication. So in this case, aseptic meningitis can occur. About 10% cases may present with aseptic meningitis. Viral inflammation of the meninges occur, and symptoms include fever, headache, stiff neck, and vomiting, and it typically resolves without a long-term effect. Another one is encephalitis, a rare but serious complication involves brain inflammation. It is seen in 1 in 6,000 cases. Symptoms include altered consciousness, seizures, and neurological deficit, may cause permanent neurological damage or death in severe cases. Another one is sensory neural deafness, sudden unilateral hearing loss due to damage to the cochlea or auditory nerve. It is also very rare, like 1 in 20,000 cases, but can be present, and it can lead to permanent damage and hearing loss. Other organ-specific complications, pancreatitis, inflammation of the pancreas causing abdominal pain, nausea, and vomiting, resolves without long-term effects in most cases. Myocarditis, inflammation of the heart muscle, rare but serious. Symptoms include chest pain, palpitations, and fatigue. Nephritis is the rare involvement of kidneys leading to hematuria or proteinuria. Arthritis is transient joint inflammation, particularly in older individuals. Now, what are the pregnancy-related complications? It can lead to miscarriage, which is the increased risk of miscarriage mostly seen in first trimester. Or if a child is born to such a lady, the person will have congenital mumps, which is very rare but does not typically lead to congenital anomalies. Now, what are the long-term sequelae? In case of orchitis, infertility can occur. In case of sensorineural damage, hearing loss, permanent hearing loss can occur, and neurological deficits, post-encephalitic complications like seizures or cognitive impairment are seen in some of the cases, but they can be present. Moving on to the diagnosis of mumps, it is mostly a clinical suspicion-based diagnosis in which the fever, parotid gland swelling, and history of exposure to a certain individual has been seen. However, there are certain new technologies that have been developed to aid the diagnosis. Reverse transcriptase PCR, polymerase chain reaction, or serology for confirmation. Additional tests based on complications, for example, CSF analysis in case the patient has meningitis. Now, treatment will be symptomatic. Use ice or heat to ease the swelling and discomfort. Drink plenty of fluids. Non-aspirin medications such as acetaminophen and ibuprofen can be used to bring a fever under control and helps with pain from swollen glands. Mumps is a highly preventable disease because of the effectiveness of MMR vaccine. Mostly kids are affected by mumps, so aspirin is not recommended because the use of aspirin has shown to develop a condition which is known as Reye's syndrome, which results in acute liver failure in these patients. Now, prevention. Mumps can be effectively prevented through vaccination and personal hygiene. Vaccination includes the MMR vaccine, which is a mixture of measles, mumps, rubella, and being the cornerstone of the prevention. So the MMR vaccine is typically administered in two doses. The first dose is given at 12 to 15 months of age in the EPI schedule, and the second dose is given at 4 to 6 years of age. This vaccination not only protects individuals from mumps, but also helps in achieving a herd immunity, reducing the overall circulation of virus in population, and prevents the complication too. Now, what are the personal hygiene measures that should be used? Don't share things that have saliva on them, cover your mouth when you're coughing or sneezing, or stay at home when you're sick for a period of at least 5 days should be uh, used for isolation period. Wash your hands often with soap, clean and disinfect the surfaces. There is another dose, which is known as dose 0. It can be given as an extra dose to infants between the ages of 6 to 12 months who may have at the higher risk of catching measles or mumps if there is a measles outbreak. Now, prevention. It was previously discussed. Good hygiene practices like regular hand washing, avoiding close contacts with infected individuals, and covering the mouth and nose when coughing or sneezing. It can help reduce the spread of virus. Outbreaks, isolation of infected individuals for at least 5 days after parotid swelling, and encouraging vaccination in susceptible population are key measures to control the spread. Now, the MMR vaccine, it is a combination vaccine that protects against three major viral infections, measles, mumps, rubella. The MMR vaccine contains live-attenuated viruses of these three diseases, which stimulate the body's immune system to develop immunity without causing the disease themselves. It is quite safe. The safety profile of the MMR vaccine is as it is well tolerated. However, certain common side effects can be seen, which are mild, and they include fever after vaccination, mild rash, swelling of gland, especially in the neck or face, or temporarily joint pain, more common in females. So serious side effects, they are rare, but may include allergic reaction or more severe complications like febrile seizures. The benefits of the vaccination far outweigh the risks, particularly in preventing the serious complications of mumps, measles, and rubella. There are certain contraindications to this vaccination, like in pregnancy. Pregnant women should not receive the MMR vaccine as it is a live vaccine. Women are advised to avoid becoming pregnant for at least 1 month after receiving this vaccine. Severe immunocompromised individuals, they were having chemotherapy or with the HIV, they should avoid the MMR vaccines unless advised by a healthcare provider. Now, what is the global impact of this vaccination on public health? It has resulted in achieve the herd immunity, which is the widespread vaccination reduces the overall circulation of virus, protecting unvaccinated individuals, including those who cannot be vaccinated due to the medical reasons. The introduction of the MMR vaccine has led to a dramatic decline in the incidence of mumps, measles, and rubella worldwide, especially in countries with high vaccine coverage. Outbreaks can still occur, particularly in areas with low vaccination rates, emphasizing the importance of maintaining high immunization coverage. So, the vaccine is recommended not only for infants and children, but also for adolescents and adults who have not been vaccinated or lack the immunity. There are certain challenges in mumps control. However, it has the prevalence and the incidence has been decreased, but there are certain challenges in eliminating the mumps completely. Inconsistent vaccination rates. One of the primary challenges in controlling mumps is low vaccination coverage, especially in certain geographic regions or communities with limited access to healthcare. Certain vaccine hesitancy has been seen because the people have been misinformed and have misconceptions, and they mistrust the vaccine, particularly in areas where the disease are rare and people may underestimate the need for vaccination. One important phenomena is waning immunity. Although the MMR vaccine provides strong protection against mumps, immunity can decline over time, particularly in adolescents and young adults. This can contribute to outbreak in high-risk groups such as college students or those in close contact settings. And then these individuals will contract the mumps virus, and they may have the probability of developing complications also. Vaccine effectiveness, similarly with the waning effect. Post-vaccination outbreaks, this also explains the waning immunity and the crowded settings. Limited access in low-income areas like remains it as a challenge with logistic barriers, lack of infrastructure, and limited healthcare funding, preventing the widespread delivery of MMR vaccine. International travel, sometimes people are traveling from countries with low vaccination coverage. They can bring the virus to countries with high vaccination rates, causing imported outbreaks. Underreporting. Mumps is often underreported due to its mild symptoms in many cases, or it can be confused with other conditions. Diagnostic delays. Early diagnosis is crucial for controlling mumps outbreaks, but diagnostic delays can occur because many healthcare providers may not immediately suspect mumps due to its similarity with other viral infections. Pandemic effect. After COVID-19 pandemic, it has disrupted the routine immunization schedules, leading to delays in childhood vaccination programs and an increase in missed doses of MMR, raising the concern about future outbreaks of mumps. Increased vulnerability, like people who have undergoing a natural disaster war zone. False information, it comes in, there is a persistent myths about the safety of MMR vaccine. Like there was a myth that it has been associated with autism. In Somalia, there was a misconception related to the vaccine. Misinformation on social media comes also. So now how to overcome these challenges? By improving the vaccine coverage, addressing the vaccine hesitancy, and improving the surveillance. Also addressing the health inequities, improving healthcare infrastructure, providing vaccination to all, develop and promote the new vaccines, and increase the public awareness regarding the vaccination and the disease and complications. Now, moving on to the recent advances in mumps. This is the title, Atypical Mumps, Are We Heading Towards an Outbreak? Published in 2024. So the abstract, the important points has been highlighted. The study highlights a shift in mumps demographics with higher age groups affected and increased incidence of complications like sensory neural hearing loss and airway compromise. International trends also suggest periodic outbreaks and evolving clinical manifestations. Post-COVID-19 pandemic. Factors contributing to mumps resurgence include lack of vaccination or vaccine efficacy, population immunity, and seasonal variation. India appears to be facing a potential mumps outbreak characterized by atypical features and increased risk of complications like sensory neural hearing loss and airway compromise. Serum amylase and CRP serve as valuable markers for disease severity. Early recognition and management of complications are crucial, emphasizing the importance of mumps immunization to mitigate the impact of the disease. ENT specialists, they should remain vigilant for emerging complications, particularly SNHL, advocating for comprehensive immunization strategies. Another one is moving past the vaccine autism controversy to examine potential vaccine neurological harms. So this has been published in 2023. So the misleading vaccine autism controversy must be set aside in favor of examining actual neurological harms associated with vaccines, including building on existing research that has been ignored. Manufacturers of vaccine must be required to conduct placebo-controlled clinical studies for existing vaccines and for government approval of new vaccines. Many probable or confirmed neurological adverse events occur within a few days or weeks after immunization and could be detected if the trials were sufficiently large. Contrary to the current opinion, large long-term placebo-controlled trials of existing and new vaccines would be relatively easy and safe to conduct. Now, moving on to the MCQ portion. Number one is a 22-year-old university student presents to the clinic with a swelling of the parotid gland, fever, and headache. The patient is fully vaccinated with the MMR vaccine and has no known history of mumps infection. Lab tests confirm mumps virus infection. The patient asks the doctor about the possible reasons for contracting mumps despite being vaccinated. Which of the following is the most likely explanation for the patient contracting mumps despite being vaccinated? A, the patient was likely exposed to a different strain of the mumps virus that is not covered by the MMR vaccine. B, immunity from MMR vaccine may wane over time, making the patient susceptible to mumps after many years. The patient may have a weaker immune system due to an underlying condition which led to the vaccine failure. The MMR vaccine does not provide protection against mumps virus, only against measles and rubella. E, the patient's infection is not due to mumps but another virus with similar symptoms. Anyone?
It could be B.
Yes, the correct answer is B. Two, a 19-year-old university student visits the clinic after a close contact with a person diagnosed with mumps. The patient reports feeling well with no swelling in the glands but mentions mild headache and fatigue over the past few days. The student is fully vaccinated with the MMR vaccine despite the lack of visible symptoms. The mumps virus is detected through laboratory testing. Which of the following is the most likely explanation for the patient's mumps infection? A, the patient is experiencing a subclinical case of mumps where the infection is present without the typical symptoms. B, the patient is suffering from an unrelated viral infection that has similar symptoms to mumps. C, the MMR vaccine failed to protect the patient against mumps entirely, causing a symptomatic infection. D, the patient has a weakened immune system leading to an atypical presentation of mumps. E, the patient has developed mumps as a result of exposure to a new strain of the mumps virus not covered by the vaccine. Okay, so the correct answer is A. The patient is experiencing a subclinical case of mumps. A 30-year-old healthy adult working in a college dormitory is exposed to a roommate diagnosed with mumps. The adult has no history of mumps infection and received only one dose of MMR vaccine in childhood. What is the individual's susceptibility to mumps? A, high risk due to incomplete vaccination. B, immune from the first MMR dose. C, low risk from one dose. D, likely to experience mild symptoms. E, not susceptible due to natural immunity. So the correct option is A, high risk due to incomplete vaccination. 4, a 24-year-old college student presents to the clinic with parotitis, fever, and headache. The patient lives in a dormitory and has no known contact with individuals diagnosed with mumps. Lab tests confirms mumps infection. The case is the only reported one in the region for the past several months. Which of the following is the most likely mode of transmission for this patient's mumps infection? A, sporadic spread due to an isolated case without any widespread outbreak. B, transmission through direct contact with a mumps infected individual in the dormitory. C, airborne and transmission from an individual outside the dormitory. D, transmission from a non-vaccinated community during a seasonal outbreak. E, spread through contaminated food or water.
C.
The correct answer is A. 5, a 15-year-old boy presents with swelling of the parotid gland, fever, and a headache. The patient's parents report that he was vaccinated with the MMR vaccine at the appropriate ages. The physician suspects mumps based on the clinical presentation. Lab test confirms the diagnosis of mumps. The physician prescribes symptomatic treatment as the infection is self-limited. Which of the following is most appropriate next step in the management of this patient with confirmed mumps? A, administer antiviral medication to reduce the severity of symptoms. B, recommend a symptomatic treatment such as pain relievers and hydration since mumps is self-limited. C, start antibiotics due to a risk of secondary bacterial infection. D, hospitalize the patient for IV fluids and isolation. E, advise the patient to receive a booster dose of MMR vaccine for immediate protection. So the answer is B, trans 6. A 17-year-old male adolescent presents with swelling in front of both ears, fever, and malaise consistent with mumps. His medical history reveals that he was vaccinated with the MMR vaccine with the recommended ages. After a few days, he developed severe unilateral testicular pain and swelling. So, which of the following is the most common complication associated with mumps in postpubertal males? A. Orchitis. B. Mumps include induced meningitis, mumps pancreatitis, oophorytis, or deafness. So, the correct answer is A. 7. A 10-year-old child presents for their routine vaccination checkup. The child has received one dose of MMR vaccine at 1 year of age. The parent asks whether the child needs a second dose, especially considering recent news about a local mumps outbreak. Based on current guidelines, what is the best recommendation for this child regarding mumps vaccination? A. Administer the second dose of MMR vaccine as soon as possible to ensure the full protection against mumps. The second dose is not necessary as the first dose of MMR vaccine provides lifelong immunity. C. Wait until the child reaches puberty to administer the second dose as mumps complications are rare before then. D. Only one dose of MMR vaccine is recommended and there is no need for any further vaccination. E. The child should receive a booster dose of mumps vaccine separate from the MMR due to a recent outbreak.
A.
E.
Yes, the correct answer is A. 8. A 3-year-old child is scheduled for their first dose of the MMR, measles, mumps, rubella vaccine. The parents express concerns about the safety of the vaccine, especially after hearing rumors about potential side effects. The child is otherwise healthy and has no contraindications for vaccination. Which of the following statements best describe the safety profile of MMR vaccine for this child? A. The MMR vaccine is generally safe with rare side effects such as mild fever rash, and the benefits outweighs the risks. B. The MMR vaccine should be avoided in children with mild illnesses as it may worsen symptoms. C. The MMR vaccine is associated with a higher risk of severe side effects like encephalitis and permanent disability. D. The MMR vaccine is not recommended for children under 5 years due to potential complications. E. The MMR vaccine is safe but should only be administered after screening for autism spectrum disorders.
B.
The correct answer is A. MMR vaccine is generally safe. 9. During an outbreak of mumps in a community with high vaccination rates, health authorities face challenges in controlling the spread of disease. Despite a large number of individuals having received the MMR vaccine, cases continue to emerge. Public health officials are investigating potential reasons for persistent spread, including vaccine hesitancy and gaps in vaccine coverage. What is the most likely challenge contributing to the ongoing spread of mumps in this vaccinated community? A is vaccine efficacy, B, vaccine hesitancy, C, increased population mobility, D, immunization gaps, E, antiviral resistance. The correct answer is D, immunization gaps. A 25-year-old medical researcher is reviewing recent advances in mumps control and prevention. They are particularly interested in new developments related to the mumps vaccine, treatment strategies, and efforts to enhance global vaccination coverage. The researcher is exploring the impact of new mumps vaccine formulations, diagnostic improvements, and potential antiviral therapies. Which of the following represents a recent advance in mumps prevention or treatment? A. Development of a single dose mumps vaccine that provides lifelong immunity. B. The introduction of mumps specific antiviral treatments that reduces the duration and severity of illness. C. Enhanced diagnostic tools such as PCR-based tests for earlier detection of mumps infection. D. The use of a new universal vaccine that protects against all types of viral infections, including mumps. E. Implementation of a new oral polio-like vaccine to prevent mumps in high-risk populations.
E.
The C is the correct answer, which is the enhanced diagnostic tools such as PCR-based tests. This is the key of the MCQs. And this is the link of the channel where the presentation will be uploaded soon. Thank you.